In the part 2 of the integumentary system coding guidelines, we are going to cover the different biopsies, excision of the lesion and the shaving. So let's start with the lecture. So by now we know that biopsy is nothing but a medical procedure that involves removing of the tissue or the cell from the body for the examination and to diagnose the medical condition or the illness. We have seen the fine needle biopsy earlier. Now here we are going to see few more other methods of biopsy. Now remember the important guideline as far as the biopsy is concerned. If the biopsy is done on one particular site, and on the same site if we have done another definitive procedure, that is the excision, shaving and debridement, then we code only for the more definitive procedure. But for that, both the procedure like the biopsy and the excision both has to happen at the same site. Now then the second important guideline is code biopsy only if it is without definitive procedure. Now I am going to take one example for you to understand this concept. Suppose there is a patient, and I'm sorry for my presentation, but suppose there is a patient and he has the two lesion, one is on the right side and one is on the left side. And on the right side of the lesion, what he does is we have done only the biopsy. Okay, and for the left side of the lesion, we have done the biopsy plus the excision. Okay, I'm just using the first letter. So on the left side, I have done both the biopsy and excision, and on the right side, I have done only the biopsy. So how am I going to code? So for the right side, I'm going to code the biopsy, and for the left side, I'm going to code only excision, not the biopsy, because on this same side there was a biopsy plus excision, and we have the guideline that if the biopsy is followed by the more definitive procedure, I am going to do only the definitive procedure, and in that case we will not code for the biopsy. So this is very, very important, and in this particular part of the integumentary we are going to learn three different biopsies, and those are tangential, punch and incisional biopsy. So these are the various different biopsies: incisional, tangential and punch. And if you see the tangential, it is slightly superficial, and here you can see that this is the tangential biopsy. So it is superficial, it is like the partial thickness or epidermal sample. The punch biopsy is full thickness, where you are taking the pen like instrument and you punch it, and then you move it in the clockwise direction. And incisional, you take a deeper cut and go till the again it's a full thickness. So these are the various technique that we are going to see. So every biopsy has the primary code and the add-on code. So let's see, the tangential has the primary code 11102 and 11103 is the add-on code for the tangential. Then the punch biopsy, again you have the primary code and the add-on code, and incisional also you have the primary code and the add-on code. So these are the guidelines. They are there in your book, that whenever the multiple biopsy techniques are performed during the same encounter, only one primary lesion biopsy code we write, and then additional biopsy code should be selected. Now pay attention to this chart, because this chart is very important, and this will explain how do we code it. Suppose in our patient we have done the two tangential biopsy, then we code the primary code for the first and then the add-on code for the second tangential biopsy. Suppose there are three punch biopsies are done, then we write the primary code and then the two add-on code, because there are three punch biopsy. Suppose there are two incisional biopsy, again we write one primary code and one add-on code. And suppose I have done one incisional biopsy, one tangential biopsy and one punch biopsy. Now how do I write? I write the incisional biopsy primary code, and for the tangential and the punch biopsy I write the add-on codes. And if I have done one punch biopsy and two tangential biopsy, then I will write one punch biopsy and followed by two tangential biopsy. These are the add-on code. So let us take these two examples for you to understand it better. Punch biopsies were taken from the three different lesions, one on the skin of the right upper right arm, one of the lower right arm, and one of the right hand. So what are the types of biopsy? Punch biopsy. How many? Three. So how will I code it? For the first punch biopsy, I am going to use the primary code, that is 11104, and the remaining two punch biopsy I am going to use the add-on code, and that is 11105 into 2, because how many regions were there? Three. Okay, so it is simple. Now the next is biopsy performed on a different lesion at the same surgical session. One is incisional biopsy with, and one is punch biopsy. Now remember, there is always a hierarchy, that if these two biopsies are there, we always write the incisional first followed by punch. So in the incisional biopsy, I am going to write the primary code, and that is 11106. And for the punch biopsy, I'm going to write 11105. Now here there is a parenthetical note also. What does it say? That you can report 11105 in conjunction with 11104 and also 11106. So it also gives you a hint that whenever you are writing the code 11106, you can write 11105 as a add-on code. So this will help you to understand that for the two different kind of biopsy, we always write the primary code for the first and then the add-on code for the second biopsy. On his lower lip and nose, lesions were identified and marked. The lower lip lesion, 4 mm in size, was shaved to the level of the superficial dermis. Utilizing 3 mm punch, a biopsy was taken of the left supratip nasal area. What are the CPT code for the procedure? So we need to eliminate the wrong answer. So first of all, 40490 is the excision biopsy of the lip, and here they have done the biopsy, but that is a superficial biopsy. Then 11104 is a punch biopsy, so we will require that code for sure. Then let us look at the B option, that is 11313. It is a shaving of the epidermal or the dermal lesion, single lesion, face, ear, eyelid, nose, lips, and the area is definitely more than 2 mm. Then 170017003, it is about the destruction, and the destruction procedure is not carried out in this case. And whenever you are solving the question related to the biopsy, please find out how the biopsy was performed. Here the destruction we did not carry out. And 111440. So after seeing all the options, let us find out what is the answer. So by studying all the four options, the option B is the correct answer, because 11313 is the first procedure performed, that was on the lesion on the lower lip removed by the shaving technique, for which we will report 11313. And 11104 is the punch biopsy that is performed on the lesion located on the nose. And remember, add-on code 11105 is only reported with the code 11104 and 11106. So we cannot use the add-on code here. And then the modifier 59 indicates that the biopsy was totally separate, performed on another lesion, otherwise it is bundled with 11310. So in this case, after studying all the code, we realize that B is the correct answer. Now the next important topic is skin tags. So skin tags are the small benign tumor that are usually harmless and painless, and they are same color as that of a skin or little darker, and they have a short narrow stalk, and usually they can range in the size from 2 millimeter to 5 millimeter or 5 centimeter. Now here there are only two code, and the first code which covers up to 15 lesion, and then there is an add-on code which talks about each additional 10 lesion. So have a look at the code. So these are the code for the skin tags, and this can be removed by scissoring or the sharp method, and these are the two code. 11200, it covers up to including the 15 lesion, and 11201, which is add-on code which includes the each additional 10 lesion. So the patient is here to see us about some skin tags on her neck and both underarm. She has had this lesion for some time. They are irritated by her clothing, each and at times have a burning sensation to them. We discussed the treatment option along with the risk. Informed consent was obtained and we proceeded. We removed 16 skin tags from the right axilla, 16 skin tags from the left axilla, 10 from the right side of the neck and 17 from the left side of the neck. What are the CPT code? So we are going to check what are the codes that are available. Remember, for the skin tags, when we remove the skin tags, we do not see the area, but we just see the number of the tags that are removed. So let us see what are the code. 111057, it is the code for the paring and cutting. Now here we have the skin tags, so we can directly go to the skin tags. 111200, it is the 15 lesion, and each additional is 111201. So let us see. Now here you can see 111201 is the add-on code and they have put a modifier 51. So without even seeing into the book, I can delete this option. Now let us see this. 111200, 111201 into 4 and 111201 into 52. Again, on the add-on code, we never write the modifier 52. So the answer B and answer D is absolutely wrong answer, and the answer A is it talks about the paring and cutting, and in our case it is the skin tag. So we are going to zero down the answer 111200 and 111201 into 5. Now the next chapter is shaving of the lesion. Shave excision is a surgical procedure that removes the skin lesion by shaving them off with a sharp blade or the scalpel. It is a common treatment for the benign skin lesion like moles, warts, keratosis and the scars. It's a superficial procedure, and it means the slicing and peeling of the epidermal and dermal layer without disturbing the subcutaneous tissue. Now, if you see the shaving code, you will have to understand from which area the shaving has been removed, because we have the body site, and this body site are divided into three different groups, and those three different groups are trunk, arms and legs, scalp, neck, hands, feet, genitalia, face, ears, eyelid, nose, lips and mucous membrane. So code each lesion separately. Do not add the diameter on the same side, okay, or the different anatomical site of the same body group. So this is very, very important, and I'm going to tell you in detail. So let's go and see. So suppose if the we have done the shaving of one lesion of 1 centimeter of the trunk. So the trunk is here, and then the shaving of the arm 1 centimeter and the face. Now here if you see the face is here, the trunk and arm they are in the same body group. So can I add them? No, we cannot add, because do not add the diameter on the same side or the different anatomical side of the same body group, because the trunk and arm is the same body group. So basically, as far as the shaving, we do not add the diameter, irrespective whether they are on the same body side or they are on the different anatomical site but of the same body group. So these are the code for the shaving lesion, and you can see that this is one particular group 11300 to 11303. It is one particular group which is called as a body group, and it mainly includes the trunk, arms and legs. And then this is the another group which is 11305 to 308. The group talks about the scalp, neck, hands and feet, and this is the third group. Remember, we always write the separate code for each lesion. When shaving a multiple lesion, use the appropriate shave codes for each lesion based on its size, regardless of how close together they are on the body. Then we put the modifier 59 if billing for the multiple lesion in the same area. Append the modifier 59 to all but the first code to indicate that each lesion is distinct procedural service. And if the primary purpose of the shave is to obtain the tissue sample for the diagnosis, a different CPT code might be needed, and that is 102. So if it is for the diagnosis purpose, then we write the tangential biopsy code, not this shaving code. So these are the very three important points that you must remember as far as the shaving codes are. So these are the codes in your group, and the best way to remember this is to bubble and highlighting. And here, there are various body group areas. So in this case, I will bubble up this particular body group, and this particular body group talks about the trunk, arms, and leg. And then you also highlight the important part, that is the dimension, because that will divide the code. So this is a bubbling and highlighting technique that you can use it all through your book for you to remember the things very, very proper. Where the patient present with a recurrent seborrheic keratosis of the left cheek, the area was marked for a shave removal. The area was infiltrated with local anesthetic, prepped and draped in sterile fashion. The lesion measured 1.8 centimeter, was shaved using 11 blade. Meticulous hemostasis was achieved using light pressure. The specimen was sent for the permanent pathology. The patient tolerated the procedure. What CPT code is reported. Now check all the codes, and then we will go and find out the answer. So the first code 11200, it talks about the skin tags. Definitely it is not a skin tag, it is a recurrent seborrheic keratosis of the left cheek. 11442, it talks about the excision of the benign lesion, and in this case it talks about the lesion which is there on the face, ears, eyelids, nose and lips. So we need to check where our lesion is in the cheek area. And then 11642 is also excision of the malignant lesion. And then 11312, it talks about the the shaving of the epidermal or dermal lesion, single lesion. And so the shaving of the lesion has been done, and we are going to send that lesion later on for the pathology, and so the answer will be B. So this is very important topic, because on this topic there will be many questions. Excision of the benign and malignant lesion. So in this case, the lesion is the area or of the abnormal tissue is called as a lesion. So in this case, the part which is looking brown is called as a lesion. Excision is a full thickness removal of the lesion, including the margin. When we use the word excision, that means we are removing the full thickness lesion. Margins are the edge of the tissue. So these are called as a margin, which are nothing but the edges of the edge of that tissue. And the repair is the closure of the defect. So after we remove this particular thing, whatever the defect is there, that we need to close it by repair. So let us see now this. So this topic is very important, so I want your complete attention. First of all, we are going to talk about the excision. Excision simply means to take it out. You have to take out something from the body. So to cut out, completely to cut out is the excision. So first of all, look up for the body side. Here, like your shave, we have the body group area. So you need to pay attention from which body area you have taken the excision, because that will decide your code. Secondly, the type of the lesion. Is the lesion benign or the malignant? Malignant means the cancerous lesion. So we have a separate code for the benign, we have the separate code for the cancerous. Then lesion diameter. We always consider what is the diameter of the lesion and code each lesion separately. Never add the excision lesion. Okay, so this is a very, very important thing. Now the next few important guidelines, and consider the highest diameter and the lowest margin. Now the next important guideline is excision plus repair. Now what happens is, whenever you are doing the excision, you are creating a defect, and sometimes we have to close that defect by suturing. So if and that suturing is called as a repair. So if the excision we have done it by the simple repair. Simple repair means superficial suturing, superficial or a single layer suturing. Then in that case we code only excision. We do not code the repair, because the money for the simple repair is included in that excision code, and that's why we code only the excision. But if it is a excision plus intermediate repair, then we code both. We code excision plus intermediate repair. So what is the intermediate repair? Let's say your excision wound is very deep. In that case, we cannot have only one layer of suturing. We will have to have a two layers of suturing, one the deeper suturing and one the top suturing. So in that case, whenever there is intermediate repair, the we have to code that separately, because the money for the intermediate repair is not included in the excision, and that's why we will code excision plus intermediate repair. So same goes for the complex repair. It is a excision plus the complex repair. Okay. Now the excision and the biopsy. If the biopsy plus excision happened, we code only the excision. I mean, for that, both the biopsy and excision has to happen at the same site. Okay, because this is very important. If the biopsy and excision it happens at the same site, I will code only more definitive procedure, and that is excision. Then excision plus surgical grafting, we code both. We code excision as well as the surgical grafting. And if the excision plus adjacent tissue transfer, if it happens, we code only the adjacent tissue transfer. Now we are going to see each and every guideline in detail. So excision is defined as a full thickness removal of the lesion. I want complete attention here. So here in this case, whenever we are talking about the excised diameter, how do I calculate that excised diameter? Here, if you see, the lesion is only 1 centimeter. Okay, this is the diameter of the lesion. The lesion is only 1 centimeter. But what I do is, whenever I am cutting this particular lesion, I leave 2 centimeter of normal tissue on both the side, and then I create a cut. So what will be the total excised diameter? To find out the total excised diameter, I use the formula excision diameter is equal to lesion diameter plus, so what is the formula? Excision diameter is equal to lesion diameter plus 2 into margin. So let us see here. What is the excision diameter? 1 centimeter plus 2 centimeter is margin, and so I will write 2 into 2, that is 4 centimeter. So what will be my excision diameter? It will not be 1 centimeter, it will be 5 centimeter, because I am interested in the excision diameter, not the lesion diameter. So this is very important for you, that this is the excised diameter and this is the lesion diameter. Now let us take when the margins are not even. So in this case, suppose this is your lesion. So the lesion is, how will I take out the diameter of the lesion? Length plus breadth. Okay, you know the formula for the area. So 2 into 1 is equal to 2 centimeter is the lesion diameter, and we have to always take the highest the margin. So we need to check what is the margin. It is 0.2 into 0.2. So 2 centimeter, 0.2 into 2 is 0.4 is equal to 2.4. So I'll be coding for 2.4 and not 2. Remember that. So everywhere, whenever you are taking the benign and malignant, check whether the lesion is benign and malignant. Check whether they have given the excised diameter or whether they have given the lesion plus the margins. So in that case, you will have to use the formula to add the margins and lesions and then code for the excised diameter. So here, these are the code which are there. I have put them into the chart, and remember what it is written here is the excised diameter including the margin. So whenever we are coding, we need to find out whether it is the excised diameter that is given or the lesion diameter is given. If the lesion diameter is given, I need to add the margin. But if the excised diameter is given, I need not, I don't have to add anything. I can pick up that code directly. So again, here there are the body group, and here there are the codes. So these are, so if you see the benign excision series is 114. So make those small observation, because it will help you to code faster. Similarly, this is the malignant chart. Everything looks the same. That is, the body group is same. Even here also they have written excised diameter including the margin. The diameter which are given in the code, they are including the margin. What is important here for you to understand, that for the malignant the code series is 116. For the benign the code series is 114. Important observation. So these are the code in your book. You can always do the technique of bubbling and highlighting. I will bubble this particular body group and then I'm going to highlight the important part. And in this case, the important thing is the excise diameter is important and even the body group is important. So maybe you can use this technique all over the book for your better understanding. And of course here another important thing is 114 series. So I can very well make out that this is a benign, and of course here it is written as a benign lesion. A 50-year-old female saw her dermatologist for removal of the basal cell carcinoma on her right arm. 8 centimeter lesion that included the margin was drawn out and 15 blade scalpel was used for full excision of the lesion. A layered closure was performed after the removal. The specimen was sent for the permanent histopathological examination. What CPT code is reported? Now, in this case, we need to underline important point. The first point is it is a basal cell carcinoma. That means it is a malignant lesion. Second is from where the lesion has been excised. It is from the right arm. Third is 8 centimeter lesion that included the margin. Okay, so it is a excised diameter. And then it is a layered closure. Layered closure was performed. That means we will require the intermediate repair, and whenever the intermediate repair has been done, we need to code that additionally. So A answer is the wrong answer because in this case they have not included the intermediate repair. Now the B, it is 11606, and then we need to check all the code. 12004, it is for the simple repair. 13121, it is for the complex repair, and 12034 is for the intermediate repair. So my answer will be answer C. And the modifier 51 is whenever we are doing the two procedure, one is excision and then the repair of the same wound, then in that case we will put the modifier 51. That is a additional procedure modifier. Now one more example. Now this is called as a case report. Again, important thing is the patient has a basal cell carcinoma. Area is left chin. Wide local excision of the 3 centimeter with 0.3 centimeter margin. So remember here what they have given is the lesion has given and then the margin was given, but they have not given the excise diameter. So we need to find out the excise diameter and the with a 4 centimeter closure. Now 4 centimeter closure, does that mean it is a simple or layered closure? So for that we need to read little bit into the procedure. The patient left chin was examined, the site of intended excision was marked, the site was then prepped, the patient was then prepped, draped and usual in the usual fashion. 15 blade scalpel was then used to make an incision in the previously marked site. It was carried down to the subcuticular fat. The lesion was sharply dissected off underlying the tissue bed using 15 blade scalpel. It was tacked for the pathological orientation. The hyperector was used for the hemostasis. The wound was then closed by advancing the tissue surrounding the lesion and closing in layers. So I got some clue with 30 Vicryl for the deep layer and following the 50 proline for the superficial skin. So that means it is in two layer. That means it is an intermediate repair. The skin closure was running the subcuticular fashion. Steri-strip was then applied. What are the procedure and diagnosis code for the encounter? So now we got all the hint. First of all, it is a basal cell carcinoma. Whenever there is operative report, the ICD codes are also given to you so that it will be easier for you to understand. Now, since it's a basal cell carcinoma, it is a malignant cancer. That eliminate my option 114 because it is a benign cancer, benign tumor or benign growth. Now A and B is there. Now we will see all the options and find out the answer. So after putting all our findings, we know that this is definitely not a benign growth. So it will take out my option C and eliminate my option C and D because these are the benign growth. and 11644 and 11643. So I am going to look for the excised diameter. 11643 talks about 2.123 centimeter, and our excised diameter is how much? It is 3.6, because 3 is the lesion plus margin is 0.3, and 2 into 0.3 is become 3.6 will be my excised diameter. So I'm going to pick up the code 11644, that is for the excision, and 12052, it is again the intermediate repair. And what is the repair? It is 4 centimeter closure. So and we have the diagnostic code C44.319, and it is for the basal cell carcinoma. So my answer is A. A 46-year-old female had a previously biopsy that indicated a positive malignant margins anteriorly on the right side of her neck, and a 0.5 centimeter margin was drawn out, and 15 blade scalpel was used for full excision of 8 centimeter lesion. Layered closure. So full excision of an 8 centimeter lesion, layered closure was performed. So we have now enough, pointers to find out, zero down our answer. So my answer will be 11626, that is for the malignant lesion, and 12044 for the repair, that is intermediate repair, and 51 is applied to indicate these are the multiple procedure that has happened on the same side, that is first is the excision followed by the repair. And this way we will conclude the part 2, and then we will move on to the part 3 of the integumentary system.